Raloxifene is another anti-resorptive medication. It is an estrogen agonist slash antagonist, depending on where it is working on the bone. Previously, it was known as a selective estrogen receptor modulator. This is going to work as an agonist at bones and an antagonist at breasts. Remove this part here if it's in your notes. It's indicated for the prevention and treatment of postmenopausal osteoporosis, and it reduces the risk of invasive breast cancer in postmenopausal women, whether or not they have osteoporosis. So really, this medication should only be used in those with invasive breast cancer, because then just the added benefit would be osteoporosis treatment. It is dosed 60 milligrams by mouth daily, and some of the adverse effects are some vasomotor symptoms and breast tenderness, spotting. So if the patient's already experiencing some of these symptoms, don't recommend this agent because those symptoms are only going to get worse, and it's going to affect the adherence. This medication has a boxed warning of fatal stroke and an increased risk of clotting. So if there's a patient that has any history of a stroke or of a clot, this medication is not recommended for them. It is recommended that breast cancer chemo prevention is used in at-risk women that are 35 years or older without a history of breast cancer. So the low to average risk, we would not use medications. However, if there is an increased risk, that would be women that are 50 years or older with a 5-year risk of invasive breast cancer greater than or equal to 3%. In these patients, we would want to use raloxifene. And tamoxifen is similar, but we're focusing on raloxifene because it's used also for osteoporosis. There's also a combination pill that has bazidoxifene in conjunction with a conjugated equine estrogens. This is used for prevention of vasomotor menopausal symptoms and osteoporosis. It's going to increase bone mineral density. However, we don't have fracture data really. But let's say a patient is having some symptoms and they need control of them and they have osteoporosis, we might want to use this medication. However, if they have a history of a fracture, this is probably not going to be the best medication for them. This is going to be safer than hormone therapy alone, because let's see, breast cancer is similar to placebo versus estrogen, where there might be an increased risk of cancer. There is no endometrial cancer with this combination. The CEE part of this combo pill is going to oppose that effect. And the side effects are going to be similar to raloxifene or any hormone therapy, specifically estrogens. Next, we are looking at hormone therapy. So we know estrogen is good for increasing bone mineral density, hence why postmenopausal women, estrogen goes down. So that's why they're going to be at an increased risk of fractures. So this is indicated for hormone therapy for prevention of osteoporosis. This is estrogen and progesterone should only be used post hysterectomy, so that must be removed before they could be used. This is not replacement therapy, so don't use this abbreviation. Instead, use MHT. It is going to be used for menopause symptoms, so really it shouldn't be prescribed just to treat osteoporosis. So it's going to be in patients that are less than 60 years old or less than 60 years past menopause. And you shouldn't be using this in any patients that have history of a heart attack, stroke, or breast cancer. The advantages of this is that it does increase good cholesterol, so HDL, and it's going to decrease the menopause symptoms. The disadvantages, though, are risk of breast cancer and some of the cardiovascular complications. So again, if there's a history anywhere on this patient's profile, hormone therapy such estrogen should not be used. Next, we have testosterone. This is going to be converted to estradiol in the body, and remember, estrogen good for bone health. It's going to be indicated for men who have hypogonadism. Now, if someone is symptomatic, we would use testosterone. If they're low fracture risk, no osteoporosis is needed. But let's say they are high fracture risk, then yes, we would want to use an osteoporosis medication. If a patient is asymptomatic, then we should not use testosterone for hypogonadism, even if the levels indicate that it's low. Osteoporosis, really, we should be using it if other medications are not adequate or working. This just has an added benefit of helping bone mineral density in patients who do have hypogonadism, or specifically in men. Last of the anti-resorptive medications is calcitonin. This is something that is actually found in your body, and what it does, it inhibits osteoclast, so it's going to inhibit resorption. The thing is, it's not really frequently used. It's not the best option. Really, you should only be using it if other medications were failed or they were not tolerated. This could be used both intranasally and subcutaneously. Some adverse effects to note are some runny nose or some irritation. If it's an injection, you would just notice some pain or redness at the site. There's also some nausea, headache, and at first there was some concern that this might increase the risk of cancer, but post-marketing analysis showed that there was actually no cancer risk. Here are some instructions that you might want to tell the patient if they were to ever get on this medication. This is something that's refrigerated. It should be primed. You want to alternate nostrils, and you want to administer this at bedtime because there is a lot of nausea associated with this. Now we're moving on to the anabolic medication. So the medications are going to build new bone. Teriparatide is a parathyroid hormone, and what it's going to do, it's going to stimulate osteoblasts, so we're going to have new bone growth. Overall, we're going to see a decrease in vertebral and non-vertebral fractures, not so much in hip fractures. It is indicated in postmenopausal women who are at high risk for fractures, also in men with primary or hypogonadal osteoporosis at high risk for fracture. So this is a medication that would be preferred over testosterone. Or if they were unresponsive to other therapies, and in patients that have glucocorticoid-induced osteoporosis. This comes in a pre-filled pen that is subcutaneously injected. It should be injected in the thigh or in the abdominal wall. Some contraindications are skeletal muscle radiation, bone cancer, hypercalcemia, because this medication also causes an increase in calcium, and in Paget's disease. Some adverse effects is orthostasis, so make sure you tell the patient that at first they might notice they're going to feel lightheaded when they stand up, so making sure that they're standing up slowly. Over time, that will resolve. There could be some nausea and some joint pain. And then again, hypercalcemia. Make sure that calcium is checked at baseline before this medication is started. Abaloparatide, similar to teriparatide, except for it's a synthetic parathyroid hormone receptor analog. Excuse me. So also gonna increase formation of the bone. It's just a slightly different signaling pathway than teriparatide. Overall, though, there is a better ratio in formation versus resorption. So overall, we're going to see more bone growth or bone building when we're comparing it to teriparatide. The bone effects are a decrease in vertebral and non-vertebral fractures, not in hip, although when you're comparing it to teriparatide, it is going to be a better effect at the hip and femoral neck compared to teriparatide, but Again, we would really want to only use this in patients where we have a concern of the vertebral or non-vertebral fracture. This is also administered subcutaneously daily, and it is expensive, so there will most of the time insurance will require a prior authorization. Now, this medication is building bone, but the patient's not going to be on it forever. So this medication should be followed with alendronate so that we can build the bone, but then also now we're preventing the osteoclast from breaking down that new bone. I already mentioned before, hypercalcemia is a common adverse reaction, so just make sure that's monitored. Also, any of the dizziness or orthostatic hypotension, just telling the patient to stand up slowly. Less common reactions are joint pain, some runny nose, UTI. And then I do want to make you aware that there is a box warning for abaloparatide of osteosarcoma or cancer of the bone. This was placed on the drug as a warning because they did see this come up in animal studies. However, it has not been seen in humans yet. Teriparatide used to have this similar box warning, but we have enough post marketing data to show that it doesn't occur in humans. Over time, hopefully, abaloparatide also, we will see that there isn't actually an increased risk of bone cancer in humans. Lastly, we have romosozumab, which is going to be both your anabolic and anti-resorptive medication. So this is a monoclonal antibody, and this is going to bind to sclerostin. This is going to inhibit, it inhibits sclerostin, which inhibits osteoblasts. So ultimately, we are increasing the work of osteoblasts, so we're building bone. This is going to decrease any new vertebral and clinical fractures, but there is no change in non-vertebral fractures. Something that could be followed after receiving rosozumab would be alendronate or denosumab, and we have data on that. Now this chart here, I don't want you to memorize the numbers, but kind of look at the trends. So we do see that the effects on the hip, neck, spine are going to be greater when you're comparing it to teriparatide and alendronate. And that's because we're having both anabolic and anti-resorptive effects.